we note that most of the hospitals in South Africa are large acute-based facilities, and although there has been increasing entry by day hospital in recent years, the hospital market seems to lack dynamism, with few entrants following similar models to the three large hospitals, that is Netcare, Mediclinic, and Life Healthcare. The relationship between facilities and practitioners is crucial to understanding competitive dynamics in the facilities market. Hospitals do not compete directly for patients, but rather compete for practitioners who refer patients to hospital. The Health Market Inquiry identified various incentives and arrangements between facilities and practitioners designed to attract practitioners to their hospitals and to maintain or increase admission rates. I now want to turn to the recommendations that we are making. And again, I do not propose to go through every recommendation that we have made, but I intend simply to focus on the main recommendation and those that relate to the two contested issues. We have not, of course, previously engaged with the stakeholders on our preliminary recommendation, and we therefore consider it appropriate, at least at this stage, to indicate the kind of criteria that we use in developing the preliminary recommendation, and also to provide a framework for determining an appropriate remedy. Now, in considering an appropriate remedy, we are required to measure or to recommend measures that are aimed at addressing harm to the competition. An appropriate remedy is one that is effective in achieving its aim. It is a remedy that is practical and that is capable of effective implementation, monitoring, and compliance. In addition, an appropriate remedy must be proportionate to the harm that's being addressed. Proportionality requires that the remedy should be the least burdensome remedy and must not be disproportionate to the harm that it seeks to remedy. The primary recommendations, the preliminary recommendation, I should say, which we have made, must be viewed as a package. We have identified multiple and interrelated failures that have an adverse effect on competition. The interventions we have proposed are similarly closely interrelated, and market failures may persist if a partial approach to implementation of the recommendation is adopted. In considering these recommendations, we would therefore urge stakeholders to consider the links between recommendations as well as the sequence of implementation of this recommendation as we specify in the preliminary recommendation. Now, turning to the recommendation that we're making in relation to the funders market. The preliminary recommendation pertaining to funders market are aimed at improving transparency, ensuring that schemes act more concertedly in the interest of scheme members, in holding administrators to account, and ensuring that schemes act to reduce supplier-induced demand and curtail excessive cost. Preliminary recommendation include the following. Firstly, medical schemes option must be simplified by introducing a base benefit option that covers catastrophic expenditure as well as out-of-hospital preventative and primary care. The base benefit option should be standardized across schemes so that it is easy to compare and will be obligatory. All medical scheme members must purchase the base benefit option. Second, we recommend that a risk adjustment mechanism be implemented with respect to base benefit package. This will remove schemes' incentive to compete on demographic risk factors such as age, and will instead encourage schemes to compete on factors such as value for money and innovative models of care. Thirdly, various recommendations have been made to improve the governance of schemes and to ensure that schemes act in the interest of members in holding administrators to account. These include ensuring that the remuneration of trustees and principal officers' remuneration is explicitly linked to objective, performance-based criteria, that minimum education and training standard be put in place for trustees and principal officers, and that schemes actively encourage member participation in annual general meetings. This could take place, for example, by increasing the quorum for properly constituted annual general meetings and making use of mobile and other platforms to facilitate remote participation by members. We also recommend that the period of election of scheme trustees be extended to give as many members and as possible an opportunity to vote. To this end, electronic voting must be considered, and voting must be completed and audited prior to the annual general meeting. And at the annual general meeting, the final result must be confirmed by auditors and officially recorded. Coming to the providers, that is on the supply side recommendation. Our primary concern in the hospital market is the high level of national and local concentration in hospital markets. The National Health Act of 2003 makes provision for certificates of need to replace hospital licenses. Some of the factors that must be considered before issuing a certificate of need include the following. Firstly, the need to ensure consistency of healthcare services development in terms of national, provincial, and municipal planning. Secondly, the need to promote an equitable distribution and rationalization of health services and healthcare resources, and the need to correct inequities based on racial, gender, economic, and geographical factors. If this process were implemented and these principles are properly applied, the new licensing framework could promote innovative entry and competition to the benefit of consumers. These provisions of the National Health Act, regrettably, are yet to be implemented. We urge the Department of Health to implement this without delay. The inquiry has also considered a number of alternatives on how you can deconcentrate the market. Some of these options that have been considered include divestiture and imposing a moratorium on issuing licenses, in particular in those areas where there is already a high concentration. However, these recommendations raise a number of issues, in particular issues of proportionality, their effectiveness, and whether or not they constitute the least intrusive means of achieving the objective of greater competition. And it is on that basis that we invite the stakeholders to make submission in this regard. But more broadly, the inquiry has found that the current regulatory measures on the supply side of the healthcare market are limited and fragmented compared with other countries where there is often a single dedicated supply side regulators. In South Africa, the supply side has generally been left to operate within a fragmented, poorly enforced regulatory system with weak oversight. The existing regulatory system does not go far enough in terms of achieving optimal healthcare outcomes and appropriate access to quality healthcare services. And for this reason, we recommend comprehensive recommendation for additional supply-side regulation, at least in 4 areas: healthcare capacity planning, conducting economic value assessment, implementation of appropriate payment mechanism, and outcome measurement registration and reporting. For effective and efficient regulatory oversight of the supply side of the healthcare market, we recommend the establishment of a dedicated healthcare regulatory authority, which we have named the Supply Side Regulator of Healthcare Services. I do not propose to focus on any of these 4 areas, but there is one which is frequently raised with the inquiry, and that is health services pricing. And one of the most frequent complaints made to us is that there is currently a tariff vacuum in the private healthcare sector that makes it very difficult for schemes and members to estimate and compare the cost of care among providers. We have 2 proposals to remedy tariff vacuum. Firstly, a regulatory solution where the supply-side regulator will set tariffs after extensive consultation with stakeholders in a public forum. Secondly, a multilateral price-setting mechanism where stakeholders conduct tariff negotiations and reach agreement under a negotiation framework determined by the supply-side regulator. In both cases, failure to reach agreement and/or fundamental disagreements with the outcomes of the process will be resolved through a process of compulsory arbitration mechanism. And regardless of the eventual form of price-setting mechanism, we recommend that the tariffs for prescribed minimum benefit should be binding, and the tariffs for non-PMB conditions will have the status of reference tariffs. Bilateral negotiations between funders and providers, not just corporate providers like hospitals and pathologists, are wholly supported by the health market inquiry. We see bilateral negotiations as essential if wider adoption of meaningful risk transfer through performance-based contract is to be attained. The inquiry also proposes that a broad group of stakeholders be involved in price-setting forum. Representatives of providers, funders, government, and civil society should also participate in the process. Now, coming to the practitioners. The health market inquiry recommends that coding system across the sector be standardized to facilitate meaningful sharing of information. The codes should be managed by a public entity. We recommend that the supply-side regulator for health be responsible for the adoption and standardization of alphanumeric codes, descriptors, and relative value units. Applications for new codes or modification of existing ones must be submitted to the regulator for review and final determination. We have also found that provider networks, such as designated service provider networks or preferred provider arrangements, are generally positive for consumers, as they reduce cost and do not unreasonably restrict choice. There are, however, concerns about the potential exclusionary effect of these networks. The health market inquiry thus recommends that there be greater transparency in the selection of designated providers to be on the scheme network, In particular, we recommend that designated service provider partners should be appointed after an open tender process, with the results of the tender being lodged with the supply-side regulator for health. Designated service provider contracts should be no longer than 2 years. Finally, the health market inquiry has found that some of the ethical rules of the HPC SA have an adverse effect on competition, and we recommend that these rules should be reviewed. The rules as currently interpreted make it difficult for multidisciplinary practices and partnerships to be set up and for effective alternative reimbursement models to be developed. The rules should be reviewed with the aim of creating an environment that allows practitioners to adopt new and innovative models that may lead to better outcomes for patients. Now, that brings me to the end of the preliminary conclusion. Now, let me say something about what we expect of the stakeholders and the public in general, for that matter. What these provisional findings do, they represent our observation on evidence that we have collected and reviewed thus far. And with a few exceptions, they are a product of extensive engagement with stakeholders on some of the profoundly difficult issues of economic models and competitive assessment which underlie our findings. And make no mistake, there are still fundamental differences between the health market inquiry and stakeholders on some of the issues covered in the report. These include the reliability of the data that we have used, the methodologies used, our application of those methodologies, as well as the primary conclusion derived from our analysis. These differences are reflected in our report. But what the provisional report does, it provides stakeholders with the opportunity to see how their comments have been dealt with in the provisional report. And if their concerns still persist, these will be dealt with during the comment period of the provisional report, which allows further opportunity for engagement on these important issues. And the provisional report, therefore, provides a basis for further engagement with stakeholders on these issues. The report, I understand, will be available this afternoon on our website. Stakeholders have until Friday, the 7th of September this year, to provide comments on provisional findings and proposed recommendation. We would urge stakeholders to engage constructively with the provisional report and provide detailed submissions in respect of our provisional findings and proposed recommendations. All submission, as always has been the case, must be substantiated and, where possible, must be accompanied by evidence to back up the submission. We will consider all comments and, if necessary, revise the report with a view to publishing our final report on the 30th of November this year. And let me conclude by thanking the stakeholders for their participation in the inquiry over the last couple of years.
Well, you're watching live visuals of the Healthcare Market Inquiry Report being released, the Competition Commission releasing details of competitive trends in the healthcare